We're going to talk about evidence-based medicine for back pain. A lot of this information is not my opinion, but it's the literature regarding evidence-based with regards to low back pain, acute and chronic. And then we're going to go through lower level spine conditioning, particularly lower back, versus high intensity training of lower back and what the benefits are and when it should be delivered. Obviously the how, you could figure that out as well. But very important, as far as acute back pain, even though we think of it as very complex, and sometimes it is, if it's simple, this is really what the guidelines suggest. And this is a guideline that was published by Denagis and Dr. Mayer. It's a really good book, and it talks about education to manage expectations to recovery, short-term use of therapies for pain relief that permit return to function, ADLs, and those would include physical therapy. I think somebody needs to silence. There we go. ADLs and work. So the sooner you get them to normal ADLs, that's the main emphasis and importance. And then note, there is no specific form of exercise that's recommended. They recommend to get them back to general ADLs and then exercise if the condition persists. Now, my question to the authors was how do you get them back to normal ADLs if you don't exercise? And they all kind of smiled. But the reality is, remember, this is a big literature review, and they were looking at really high quality studies. And a lot of the clinical studies were disqualified. So a lot of the McKinsey clinical studies, even some of the lower level studies on transverse abdominis activation and multifidus, they weren't high quality studies or smaller clinical studies. So regardless of our opinion, this is how simple it can be. When they're talking about managing education for expectations of letting the patient know that 80% of people get back pain. Pain is normal when you have back pain. That's why they call it back pain. You want to decatastrophize. You want to explain to them that 90% of people get better within 3 months, but also it's recurrent. So it's very important to get back to your normal ADLs and make sure you listen to your therapist and so forth. From there, you listen to questions and engage the patient on recovery. And then what are we treating? So that was acute back pain, right? What are we treating when we treat chronic back pain? So somebody who's had pain for greater than 3 months, per definition, 6 months and above. We have some patients that come in 3 to 4, 5, 6 years with chronic pain to our facility. So are we treating a sprain strain? Are we treating pain? Degenerative disc disease, that's one of my favorites. Piriformis syndrome, SI syndrome, that's what I diagnosed when I first came out of school. Those were my primary diagnoses. HMP, herniated nucleus pulposus. Are you treating sciatica? Facet syndromes, short hamstring, another one of my favorites, or other short muscles that you may or may not have measured, but it's in your plan of care. And it goes on, the list goes on and on. So are we really treating these diagnoses several months out to years out? That would be my question to you guys and gals. Or are we treating this? And this is a real pain drawing from a real patient. So definitely we're treating non-diagnostic specific. So again, what are we treating? So per medical necessity, most clinical trials are 8 to 12 weeks, 16 weeks. That's about as long as I've seen. There are some studies emerging now that are tracking a year to 5 years later, but there's not, most of them are pretty short. So we are likely treating these syndromes, right? So after 2 to 3 years, 4 years, you're likely not treating degenerative disc disease. That's a normal disease process. You're also not, you're going to be treating chronic pain syndrome, fear avoidance behavior. And then we have a lot of biopsychosocial disorders. You got patients who will catastrophize. Patients that have become very sedentary, they've gained weight, they're deconditioned. And so that's what we're treating. To me, pain is a symptom, really. Sciatica is a symptom, but you can make your own judgment. And then from there, don't forget, we're actually treating patients. This was Don Codges. Unfortunately, Don passed away. He had a cancer in the spine, and he let us use these slides and also talk about his case for educational purposes. He was a long-term patient of ours for 20 years. And one of our therapists actually picked up that Don had unrelenting pain at night, and she could not reproduce his movements or reproduce the pain with movements. So it wasn't mechanical. But never forget that we're actually treating real patients, and we have to respect that and make sure we have the patient's best interest. So phases of care, one of the things that's really easy to understand and can help organize what you do. You're doing a lot of these things, but to help frame it, everybody understands acute, subacute, chronic, and during the acute phase, you're going to have inflammatory responses. You're going to have swelling. You're going to have probably less weight-bearing abilities. You're also constantly assessing because you don't know if the ligament's torn. You don't know exactly what may be going on. And those are the first 1 through 3 months of treatment. So 1 day to 3 months of treatment. This is where lower level things come into play, like isometric exercises, passive, move to active, moving to very light gravity-driven exercises, things like that. From there, then phase 2 would be subacute. You know what things to progress. The patient's not weight-bearing, and you know how to progress accordingly. Or the pain is centralized, and you know what directional preference you have. Oh, it's a post-surgical case, and you know what to do with a post-surgical and how to progress them. You also know the red flags of post-surgical cases. So we know that we introduce certain movements at a later time, depending on the surgery, healing time, etc. And then phase 3 would be loading. That's when we load with outside of gravity, when we're actually loading weights. In phase 2, you may be doing PNF, you may be doing gravity-driven exercises, you may be doing bands, light weights, very light weights. And then in phase 3 is when we really start to load. And the interesting part is that in MDRS and spine and sport, we've been able to isolate the spine and actually load it just like you would a knee or a shoulder. And that's where we have several publications and evidence to support that. And we'll go through that evidence later on through the presentation. So, and then phase 4 would be they're independent, they're on a gym program, or it's an athlete and they're back playing fully practice and participating in the sporting event fully. And then knowing about the patient's level of function, their current and their past. So their past level of function, you can ascertain through a history examination. I would urge you to use the information from your patient reported outcomes that right now we're kind of thrown into that MIPS black box. And also I'd encourage to do performance tests. That's something that could really provide more robust information for the plan of care on how to advance them and also how to dose your exercise plan accordingly. Because I would challenge you that if it's not a post-surgical case or an acute case, you may not have enough information just from the evaluation to provide a very specific plan of care for that patient. So listen to your patient's preferences and values as well. Don't just let them know what a great therapist and what your credentials are, but listen to what questions they have. Some things to them may be more important than some of the things that we feel is important. They may want to go back to a certain hobby or a certain occupation, or there's a certain thing that they want to achieve, and we should definitely listen to that, see how we can use that to motivate them and make sure they understand expectations to recovery and progress in a good structured manner. So progress treatment accordingly. Don't get stuck in a phase. You don't want to be stuck in phase 1 very long. Phase 1, as you'll see, should be days to weeks. with a lighter level until they're stable. Phase 2 is going to be weeks to maybe a month or several months. And then phase 3 would be anybody who's past the third month. You should consider phase 3. Look at the stability first and then see if you can put them into phase 3. More and less is not better. You want to try to dose accordingly. If you give not enough of a medication, you underdose, or if you overdose, we know those aren't good things. And it's the same in physical medicine. If we underdose, we may waste visits. We may not get the patient to where they need to be for their past level of function or their occupational demands or back into performing as an athlete. And if you overdose, we can injure them. So use all your manual skills, your clinical skills, but don't have the patient stuck in a phase. And then using performance tests and outcome measures, you can become more pragmatic. And when you become more pragmatic and give higher level ADL that are matching those outcomes and performance tests, you're going to see you may replace several linear exercises for one or two highly functional. You still treat them for the same amount of time, but what you'll do is you're going to be typing less on your EMR and making things more simple and measurable, because now they're tied to those outcome and performance tests. Quality of care, again, kind of touched on this on the previous slide, but measure baseline, progress, and outcomes. I can't imagine not measuring a baseline or progress. It'd be like treating somebody with a blindfold. Educate the patient regarding expectations to recovery, reassure them that what you're doing is safe, and show them with test retests. You can do your manual and show them that mobility is actually many times helps pain, not increase pain. Practice evidence medicine and looking at patient values, and use your clinical expertise. Provide the measurable dose, just like we talked about, exercise and manual. Communicate frequently with patient-centered care and what the patient's values are. And then I know, compliance gets a bad rap, but compliance and what Matt does help quality of care. So we have better notes. It reflects on what you do, tells a story. And I am 1,000% convinced, and the literature supports this. The more you're in compliance and the more quality of care, evidence-based care you provide, a lot of times that hour of care, you're billing, everything else follows. So we don't have to touch on the KPIs if we focus on quality of care. Typically the KPIs will follow. And then, we want to have value. So we want to provide good customer service, measure patient satisfaction. That leads to repeat customers, and we create a demand. And fortunately for us, we have created that demand. Now we have to hire enough staff and really set up the infrastructure and decrease barriers in the clinic so we can make life a bit easier for you, make sure that our therapists are taken care of, and also that our patients are taken care of, and we provide the highest quality of care. So now we're going to talk about motor control exercises, which are lower level exercises. They're very beneficial, particularly in the acute phase. But this is the literature that supports it, and you can make your own decision. So there are a few randomized controlled trials. As of 2021, we have to update for 22. There's 2 systematic reviews, and I just showed them to you. These are the systematic reviews. There is strong evidence that they're no more effective than a less specific general exercise program. But that's okay, because there's moderate evidence to show that they're effective in improving pain and function. And that's typically why you provide these, to facilitate neuromuscular reeducation, to get the patient moving, and to provide some improved function and pain relief. And they're not more effective than manual medicine, and that's what the consensus shows. So we know the mechanism, transverse abdominis, multifidus, quadratus lumborum. We do co-contractions and to enhance stability. So we're not going past end range. You're not loading, okay? But it does facilitate motor control of deep muscles to improve firing patterns during functional activities. And so that could be a good base in the acute stage, and sometimes in subacute, to improve the ability so you can introduce higher level ADL exercises. So if we look at these exercises, they're reproducible, mechanical patterns of lumbo-pelvic rhythm, follow specific plane of movement, or functional tasks, although I would not say that these are truly functional, but that would be the consensus there. There is support specifically for the multifidus activation and asymmetry. It's very interesting that Hydes and Richardson et al. In 1994 out of Queensland, Australia, and we actually sent therapists there to study the program because it was a very novel approach then. But when you injure your back, the ipsilateral side of pain, or where you actually injure your back, and shrinks immediately. So you have atrophy immediately. And from there, if you reverse that, you can reverse it with transverse abdominis activation and abdominal hollowing and multifidus activation and exercises. Then that atrophy can be reversed and the muscle normalized, and also the back pain improves. Now, again, this was only done on acute pain patients. And that's something that you really need to think of because it's a very low level intervention, which is very useful in the acute stage. Okay, it's not progressing for some reason. There we go. Okay, so here's an example. This is abdominal hollowing, and this is multifidus activation by lifting your knee. The next progression would be to extend your leg. Now, when Hydes and Richardson did the actual research, they used needle EMG, and they also use ultrasound, diagnostic ultrasound concurrently. And we have done this in some of our research, and we also attempted it in the clinic, although in the clinic it was not practical or pragmatic. But it's a very good technique, particularly for acute patients. And then I'll show you where we would recommend the use of these lower level exercises. So from there, lumbar stabilization, sometimes you can use balls, you can use different equipment, floor, mats, etc. This is a nice study because it shows the progression. So this is, if you're down to the last slide, to the bottom right, you're going to see that you need to isolate the pelvis, just like on the Medix machine. And then the next to that is something that looks more like a Roman chair or a glute machine. And as you go to the other exercises, they become lighter. So the lightest one would be the bridge, the bird dog, then kind of like the superhero. Then you start to isolate the pelvis. And that pelvis isolation, because remember, the pelvis will rotate after 60 degrees. And then you're being held by ligaments. The muscles aren't firing. So if you want to truly isolate the back, you have to isolate the pelvis. And that's how we have done it. It's not very functional, but once you get that weak link activated and you get those muscles to work properly, then you can introduce all your functional training that you want at a higher level. So from there, our recommendation for motor control exercises would be acute and subacute the first 3 months. Okay. Unrelenting back pain, guarding without directional preference. They're very low level, 2 to 3 minutes, but that's appropriate for the acute stage because, again, you don't want to cause more damage. You have tissue inflammation, just like Eric wrote several chapters on PRP and different biologic injections. And during that phase, you don't want to introduce anything harsh or anything that's going to load significantly. Post-surgical fusion patients, obviously you can use some of these exercises as long as it's not interfering or causing any biomechanical torque on the fusion, right? You want to make sure they're fused, but you can certainly do multifidus activation and lower level things with a fusion. And then they're short duration. You wouldn't want to be using these low level exercises on a chronic pain patient 2 years later unless they have a flare-up. But they're days to weeks. So you're not going to be using these months and years later. And then you want to DC the patient once you find a directional preference, or you have stability where you can start strengthening properly. And then one caveat is don't repeat if they previously failed. You know, if you have a history and they've been to several chiropractors and several physical therapists, and they've done these exercises. Obviously, I would not start with these exercises. So I would educate the patient that we're past the acute and subacute phase, and you've done these exercises, you're chronic, you're not improving, so we're going to progress you to phase 2 or phase 3. So any questions so far on the acute, subacute phases of care or the motor control exercises? Okay, we'll keep going through. So now we're going to look at the evidence on higher level training and higher level exercises. And this is based on several chapters that came out of the Spine Journal. And I say chapters because there are consecutive publications. And it showed all the evidence of extensor training and in many cases isolating the lumbar spine or the cervical spine. So quite a bit more evidence here, and there's a lot more evidence emerging. And finally, the nice thing is that the evidence is aligning to what we've done, and what I know provides us a competitive advantage to other providers that are hesitant of moving the spine, because that's one of the things that's happened over the years. Is past 50 years, we learned to immobilize the spine and take it easy and don't load it. And some people are still afraid of that until they see the literature, or they start using it and see that it's no different than a shoulder or a knee or any other body part. So there are 2 systematic reviews. I just showed them to you. There's 23 to 25 publications. We've done some of those publications as well. And lumbar extensor strengthening alone with co-interventions is more effective than treatment and passive physical modalities in improving disability, quality of life, muscular strength, endurance. High intensity training of spine is now emerging as a clear benefit compared to other exercises. And so there's benefits on diagnoses, benefiting healing, benefiting chronic pain patients. And then if you don't use them, obviously the benefits are lost, but the idea is to get the patient to be involved in high level ADLs back to normal. And hopefully they don't lose that if you strengthen the weak link first. And they're more effective than stabilization exercises because they cause hypertrophy. And so they do increase hypertrophy of the muscle and that muscle health and structures around it as well. So extensor strengthening, significant strength and endurance gain through overloading in time, significant hypertrophy. Reminder too, there are chemical and structural changes. Mooney et al. Did several studies where they actually took out synovial fluid from the different spinal joints, and the pH changes are seen in chronic patients. And then once those patients are moving those joints again, the pH normalizes and the patient has more mobility and a lot more decreases in psychosocial issues and ability to work and so forth. They're going to be at moderate to high level to very high level METs, depending on what the patient's needs are. And they also develop stability for higher ADLs. So typically you could work in one plane and then you add different planes as they become more functional. ACSM recommends 15 to 25 reps, optimal for clinical populations. That's what they've found in studies in Florida. Dr. Pollack, other doctors that were involved in the ACSM then were instrumental in the ACSM, found that twice a week, because you're isolating and working these structures loaded heavily, is sufficient and optimal for the isolation and treatment of the neck and the back. So you've seen these before, but I'm going to show them again because it shows the different changes. This was published by our foundation. You can see the fatty infiltration. So if you could also say this is an older individual versus a younger, but no, they're the same age. And what muscles do is they actually proliferate with fat. And the same thing occurs in the rotator cuff. And the rotator cuff, there's also the same evidence where the muscle ceases to work and you're going to get fatty infiltration, chronic pain, disuse. The muscle atrophies, although it looks larger because it infiltrates with fat. From there, you can actually reverse that. This is doing high intensity isolated training in lumbar spine. And this is not a year later. This is 16 sessions later. And sometimes you don't need 16 sessions, but you can really make a reversal. And what is not seen on the slide is that these patients also decrease their psychosocial scores. So they had improved SF-36 scores, improved oswestry, many returned to work and returned to normal activities. And these were patients who had pain for greater than 2 years. So pretty chronic. You can choose different methodologies. You know, we like to start with machines. They're in one plane, so they're safer, even though they're not functional. So in many of the San Diego clinics, we have MEDEX, and you can load progressively. It's has many publications, but it requires a larger floor plan, and they're expensive. So there are other ways you can do it isometrically, but then you run out of planes, right? Like on the table there, doing that Bjorn Sorensen, or on the Roman chair. And then you can do functional things, kettlebells, good mornings, crate lifting, etc. Those are more functional. You have to pay more attention to make sure there's good stability, because those could lead to greater possibility of having an injury if you're not careful and you load too much. So here's some of the evidence on the Roman chair. There's several publications on the back strong. One was in spine. And then there's several out of USC showing improvement with post-laminectomy patients. You can put them on there as soon as 30 days if their leg pain is stable. And then here's the Roman chair again, showing multifidus, latissimus thoracis, ilicolis lumbarum, quadratus lumborum, the psoas. And you can see before and after, and we can actually show that those muscles are the muscles that we work out. And believe it or not, this is important publication, because many times you're doing something, you're exercising, and you took a course somewhere and they tell you that that's what you're doing, but you really don't know until you do these studies and publications if that's really what you're doing. Here's the way that you can measure. So this is one of the performance tests that we recommend. Here's a Bjorn Sorensen modified. You could do this on the Roman chair. If it's a firefighter, you have normative data. Then mathematically, you can show the patient if they're improving or not improving. That test has a very high correlation with pain. So you would have pain on that day, or that you're going to have a back pain episode within a year, miss 2 weeks off work, and require medical treatment. And then we have the EDO test, and the EDO test is less strenuous, so you can use it on patients who are less stable. Now, I would not use these tests on acute patients because it's probably not medically necessary, but you could use it, print out a report, educate them about recovery, and really have another tool in your pocket when you're treating these chronic back pain patients. The Roman chair is interesting because you can change the angle, so you can accommodate lower level patients and higher level patients. It isolates the lower back. I tell patients it's going to burn like you have a knife in your back. It's been published safe, so that was published in Spine. And again, there's several publications, and we actually published a protocol, and that's part of your DNA now. Spine and Sport participated in gathering information and helping to publish this through our Spine and Sport Foundation, but not too many PT providers have published protocols, particularly for spine. And I think it provides us a competitive advantage when you market doctors, and you can educate patients that it's safe and that there's publications, and you can offer those for them. From there, again, we showed the MEDEX. You can do more functional training like kettlebells, and a lot of you guys and gals are doing this in the clinics. But again, this would be more functional. I didn't add other slides, but you could do crate lifting. You could do a lot of different things to strengthen the back, and there's ways that you can functionally isolate the back and focus on the back or neck muscles. You're going to have obviously more function. This is a higher level technique, and the patient should be highly stable before you do these. Okay, so recommendation for extensor strengthening. When we do isolated strengthening, it would be subacute, 1 month to 3 months. Okay. Directional preference, stability. You're going to have high level conditioning, so the patient has to be fairly stable to start these, but you can progress them through the whole protocol and start them at a lighter level. Post-surgical fusions, you want to make sure they're fused. Make sure you have permission from the doctor to start working the fusion. Post-laminectomy, discectomies past 30 days if you have some stability on the leg pain. And then usage would be weeks to months. So remember on the acute, we said days to weeks. Subacute, you're looking at weeks to months, and now you're looking at weeks to months as well. And then obviously you can DC once you see that the performance tests are achieved or they return to work or whatever your goal was. And then I can guarantee you that this was likely not performed in another facility. And so if you have a patient that's chronic, and it's your decision as a clinician, but I'd like to try things differently. If something hasn't worked, I would like to try something that would work. So are there any questions on high intensity training or isolated spine conditioning? Okay, we'll move on. Okay, and then the next avenue, which is the future, is prevention. And so I just wanted to share with you guys, and hopefully you will have some questions at the end, that prevention is a really good model. So it's one of the most difficult things to prove as a researcher, because there's too many outside factors. You could say, oh, we did this program and therefore, our firefighters had less injuries. Yeah, well, good luck with that when they review it. And, there were no fires that year, and maybe there's new managers, and maybe they had new equipment, and maybe you had data pollution. A fireman talked to another fireman and polluted the study. So it's really difficult. You have to have really large ends, and you have to have a lot of funding to be able to do injury prevention. But the beauty of it is we truly believe in the Spine and Sport Foundation that if we could figure out prevention, we could incorporate a lot of these principles in the clinic for treatment and for prevention. So we truly believe this is going to be the future for spine care. So there are not too many reviews. There's one big systematic review, and the consensus is that exercise combined with education is most beneficial. And so definitely that should be carried into treatment approaches in the clinic. And that really can help improve our quality of care. And by the way, I would assume that the majority of us are doing that, and you guys do quite well at this. Right now, to give you a couple examples, we just finished our 4th grant with FEMA and Homeland Security. We've been really fortunate to receive funding up to the 4th stage where we delivered services. So I want to show you what we did. But this was a large study. Unfortunately, COVID hit. So our end ended up being 400. Our end before that was 1,500. And then with COVID, it really reduced the number of firefighters that participated. I don't know if you guys recall, but at the beginning of COVID, we couldn't even enter a fire station. Remember, there was no vaccinations. And so we had to stop the whole study, and that kind of screwed us up. Fortunately, Dr. Mayer figured out he was already doing telehealth, and we implemented the rest of the protocol through telehealth. And what was really interesting is the firefighters preferred physical therapists delivering the services. So several therapists from Spine and Sport volunteered to be part of the study and deliver the telehealth services, and off company time. So they were doing this at night, they were doing this on weekends, and they were actually taking firefighters through injury prevention exercises, and working out their whole bodies really. So we had 400 firefighters at the end of the study, 15 departments, and you can see some of the fire departments there. We completed baseline assessments, risk assessment, and everything was delivered through COVID. What I think is very promising in the future of this is that not everybody got the same treatment. And I truly believe that's going to be the future of physical medicine. We do physical therapy, so you come in and we do physical therapy. But if you have a lot of psychosocial issues, you have some other issues that we can't address, we still give you physical therapy, right? So our therapists need to have better tools to be able to help them with psychosocial issues, with how to screen for that. What do you do? Can we talk to the doctor and get a referral? We don't just want to provide in the future We have a hammer and a nail, and we nail that nail as hard as we can, right? So here, depending on the risk assessment, you were delivered different therapies, okay? And that way you can concentrate your resources and better spend the resources, and it's going to be better outcome for the patient. So here are the results. So after 9 months, waist circumference went down by 2 inches. That's significant. Back muscular endurance improved by 72 seconds. That is outstanding. And then core muscular endurance by 29 seconds. Okay. From there, the exercise frequency improved by 1 day a week. It doesn't seem like much, but that's a huge improvement to get somebody to exercise an extra day a week. And then their sleep quality improved significantly based on the Pittsburgh Sleep Quality Index, which is something too that UCSD uses. They have a big female study doing sleep disorders. So everything that was tracked and baseline improved significantly. And now that's going to be published. And what I'm really proud is all the physical therapists that helped conduct the study and in a pinch provide the telehealth, on off hours and very hard work. So that was a FIRE study. In contrast, here's George Childs. This is a study in the military, and then I'll show you the study in the military that the foundation took part of. But it was a 2-year study, and basically they were doing core stabilization exercises, neuromuscular facilitation, low level of the military, and they found no benefit. So again, this kind of showcases that there is a place for low level exercises, but that would be more in the acute and subacute stage. When you have higher demands and you're chronic, you're going to need higher level exercises. Now, again, you as a clinician need to decide, but I think that information and knowing the evidence behind it is power. And then you can make better decisions as a clinician as to how you make your plan of care more robust and make sure that it fits the patient's needs, not just what you learn in a seminar or what we learned in school 30 years ago. Like in my case, the stuff that I learned is so outdated that sometimes I go back and I laugh at some of the stuff we used to do. Okay, so from there, oh, by the way, the military is not going to fund anything on lower level care. They're just not going to fund that anymore. From there, this was done in South Florida, University of South Florida, with Dr. Quillen. He's a physical therapist, PhD. He's no longer there, but he worked with John Mayer, and they were able to get DoD funding, and they did high intensity progressive exercises. Now, unfortunately, we were trying to do kettlebells and dumbbells, but this general was on the medics, and he insisted that they use medics machines, which would be highly impractical in our opinion to use in the military, but that's what they funded. They use outcome measures, and then I'll show you the difference. This was published. I do have the publications for these studies if you wish to have them. But look at the difference here. Hold on, I'm going to move because I can't see. Look at the high intensity exercises, and then look at what was called core conditioning neural facilitation. And you can see that there's a significant difference. Now, the interesting part of this study is that we asked for a frequency of 3 times a week, and the military said, no way, we're deploying, we're training. This is going to be voluntary, and you can only do it once a week. And I told Dr. Mayer, there's no way that they're going to get significant gains by doing training once a week. And he said, well, we already have the funding, we have to carry it through. And so we did. Another difficult thing in the study was the physical therapists were very hesitant to load people and progress a load on the medics machines. So we really they were good therapists, by the way, but they were afraid that they were going to injure somebody. But we had to show them the data that it's been published safe. And if they work within the protocol and use a standardized protocol published, it's standardized, you're going to replicate that. Sure enough, there were no injuries. And the therapists eventually became very adept and very comfortable at progressing lumbar training with weights. And they did it accordingly, and the results were outstanding. If you look at the control group, again, there was no significant statistical difference on increasing back strength or endurance. And again, that's doing the lower level exercises. And then the higher level exercises, loading with weight and isolating the spine by not letting the pelvis rotate, showed significant improvement. Now, we tried to get additional funding last year for this, but with COVID and everything, it was declined. So we're going to try again, because the next step of this, okay, great, you got them stronger, but does it prevent injury? And to do that, we would need a lot more significant funding, a lot more time. So the evidence-based medicine to date on prevention and also on treatment, extensor strengthening exercises appear to be more promising than core motor control. Definitely there's place for both. Again, motor control and core conditioning, those are going to be lower level, more acute, subacute, just like on the knee and the shoulder. We start with lower level during the acute phase. We keep in one plane, and then as there's more stability, you add other planes or more complex movements, and then you go into complex ADLs. Now, there is emerging literature now, which is exciting, the last 2 years, 3 years, that high intensity training emerges superior for treatment of chronic low back pain. Everything from older adults, because they require more training of muscles because you lose a lot of muscle mass. So it is actually archaic thinking that Medicare patients are less stable and don't load them with weights. You could just load them appropriately and you're going to have better results. And it's better for adults over 65 to do some weight training, because it's going to reverse some of that fatty infiltration if they have chronic pain and so forth. And also because of the loss of muscle mass. We do have to do a lot more studies. The studies are very short. Like I said, most studies go to 12 weeks, 16 weeks. It'd be nice to have studies in the 1 year, 3 or 5 years. You know, the firefighter study we did now was 9 months and then a 1 year follow-up. But that's not even enough information for injury prevention. And then hopefully we have more funding opportunities, because we could really like a subject, but without funding, it's hard to do the research. So, you know, our proposal is, do you want to feel better, or do you want to get better, or do you want to do both, right? And this is actually a real individual. She's very strong, and you could tell that she's in that Medicare range. Okay, so thanks for your time today. I hope this is helpful.